Okay, so what's useful about this is that it kind of goes back is that we conducted the first cervical and lumbar FDA clinical trials for artificial discs in Los Angeles and the whole West Coast. The lumbar disc in 2002, the first cervical disc in 2004. So we have a little bit of experience of artificial discs. What's interesting is that at our shop in Los Angeles at Cedars-Sinai, it's probably better off referred to as an artificial disc factory. We have some surgeons there that they've done way more than I have, even though I've been doing it longer than anybody. But there's just a lot of experience, and what's interesting about it is it's pushing the envelope in a lot of very interesting ways, which I was looking at some old PowerPoints of mine back from 2004 and things that I said you shouldn't, couldn't, or wouldn't, or didn't know how to do. We're doing them nowadays. It's amazing that we have pushed this technology. The artificial discs have improved to the point that we're doing things that are pushing the envelope is really what it is. And that's what this talk is about. It's about pushing the envelope. It's also about how not to use implants and use the spine. That's one of my old mantras, is that things like laminectomies, discectomies, there are a lot of procedures that we can do, and just because somebody has a problem doesn't mean that they need some kind of implants put in. Because to quote one of the surgeons that I work with, and very talented guy, he said, the best disc that you have is the one that God put in you. So that's a good thing to keep in mind. But in the cervical spine, we have all those procedures. There's a lot of new things that are happening. And I mentioned artificial discs, and that's kind of where this talk's going to go. But there's a lot of times when somebody has a problem, we don't necessarily have to do implants. Because, let's see if I can make this video. Can you make that video run? Just click down at the bottom of this. There you go. So look at the facet joints above and below this fusion. Well, mostly you can see it above, but look what kind of strain. These are old pictures, but not everybody's seen them. And what's amazing is how the mechanics are changed when you fuse the spinal column. And there's data that says bad things happen. Not absolutely. There are people that can have a fusion and they can get a run out of the adjacent segments for 30 years. I've seen people, I haven't been operating 30 years, but getting close to it, but I've seen people that had fusions and come back 30 years later and they finally need an operation. I've seen people come back in a year or two also. I've seen people come back in a few months. That's usually because maybe something that I decompressed didn't work, and maybe they did need a fusion, or maybe they needed an artificial disc. So anyway, here is a God-made fusion. Okay, it's a Klippel-Feil deformity. What happens when the fusions are congenital and the patient's born with it, and there are two discs in this patient that the adjacent segments, and I don't remember this patient's story at all, but it's a unique picture, and the way that we've treated these in the past, if and when they become symptomatic, they usually get a fusion. So what are the treatment options to spinal fusion? Okay, you can do laminectomies for spinal stenosis. You can do foraminotomies for cervical stenosis and radiculopathy, and lumbar stenosis and radiculopathy. If there's a disc problem, you can deal with a disc. Those operations are all done from the back side of the spine for cervical stenosis. We do laminoplasties also. I have a number of patients, I didn't include it in this talk, but there's a number of patients that I've operated on 20 years ago that I've subsequently done some cervical foraminotomies on because they had a cervical stenosis and myelopathy. We did a laminoplasty on them that many years ago, and they come back. I actually have one who's going to come back and have a couple artificial discs put in because he finally wore out the discs 20 years later. Danielle, I think you know the guy. Fusion or an artificial disc. That's an interesting concept, or fusion versus artificial disc and a fusion hybrid. Now, the hybrid's a whole concept that I don't know what to think about it. There are a few places I think it's appropriate. There are a few places that people are doing some things that are unusual out there, and we'll see some of those, and I'll show a few cases. The history is that lumbar disc goes back to 1984 and was invented by actually a Olympic gymnast, Karen Buettner-Jans, who is also became an orthopedic surgeon, and she was one of the key developers of the Charité disc. And in the early 80s, this first cervical disc, there were some other devices that were stuck between the vertebrae, but these are the devices that were actually made. And the Cummins disc by Brian Cummins in Bristol, England, was made in 1991. And actually, that disc persists today as the prestige disc in multiple iterations later. So, but where do we stand today? Okay, if somebody's got radiculopathy, and this is what I teach to young surgeons, radiculopathy, you got arm pain or leg pain, what do? Look for the nerve, okay? You need an implant? Not necessarily. In fact, I don't start thinking that. If somebody's got myelopathy or spinal cord compression, you think decompression. I mean, if they don't have neck pain, back pain, or they don't have some axial pain associated with it, or it's not the predominant problem and their nerve or spinal cord compression problem is, you treat that, and a lot of their axial pain will get better. What about axial neck pain? You can do decompression for some of those people, and sometimes people can have a herniated disc and have only axial pain in their neck or their back. I mean, that's one of those things. It takes a little bit of kind of judgment, experience, skill, and maybe a little bit of just insight into people. You got to be able to read and talk to people. What about things like cervical deformity and lumbar deformity? Well, we're not going to do too many motion preservations for real, true deformity problems, but when somebody has a little bit of kyphosis in their cervical spine doesn't mean that they're precluded. All of these kind of rules that have been written over the years and since the 80s when I started doing this stuff is that a little bit of bend in the cervical spine does not absolutely mandate somebody doing a big front and back fusion. It really does not. It's just having as I said, a little bit of knowledge and experience, and maybe a little bit of bravado to go do an operation and say, you know what, this kind of flies in the face of what other people usually do. What about degenerative spondylolisthesis? Okay, these are people that have a little bit of slippage of the vertebra, they have a little spinal stenosis. You know, we all still try and figure out which ones we can decompress without doing a fusion. There are some people that need a fusion. There are some people that look like they need a fusion, and I've actually done some operations on them through the years, and they do fine without a fusion, interestingly. What about lytic spondylolisthesis? Well, in the room here, a couple of the co-authors that are sitting at the corners again, that we fixed lytic spondylolisthesis also. And we wrote some papers about it in young patients that haven't worn out their disc yet. Usually the teenagers or early 20s, you can repair them and preserve their motion in their spine. So what about artificial discs? It's come a long way since the early 2000s. There's data out there that is accumulating. Most of it was done with single-level cervical disc replacement with multiple different devices. There's a half a dozen, or I think 6 or 7 of them that are on the market, and FDA has approved them. There are a few studies out there that are approaching 10 years, such as this one. There's a 2-level study. I'll allude to that one and show some things in a moment. But these look like they have promise, and time will tell. You know, all the studies that are 2 years, 5 years, there's some 7-year studies. Really, until you get out there 10 years, you really, really can't make any final conclusions. From across the seas and oceans, there's some things that are out there that are being done that are off-label, and we do some off-label things as well. These are some combination of hybrids, fusions, and artificial discs in combination. You know, we don't really know and have much information about how these things are doing. They seem to not really make much sense to me, because unless that truly is the only option, and why do people do a fusion one place and not put an artificial disc in at that other place? They don't always make sense to me. In fact, if you're going to try and preserve motion with artificial discs, why not put them in at all levels if you can. So this is a study that actually just came out. One of the authors here is one of the guys at our shop, Todd Landman. Very talented surgeon, creative guy in a lot of ways. But this is really, I think, one of the biggest landmark studies about longitudinal experience of cervical arthroplasty. These are the basics. This is, the single-level patient. It was actually hard to find them during the clinical trials that we did to do a case like this, and somebody with essentially a normal-looking neck except having a single-level degenerative and herniated disc. The two-level patients, this is actually, and I've got a number of, the rest of the talk is really about a number of cases that are just kind of out there a little bit. Pushing the envelope is what it really is, and that's why these things are kind of fun talks to give, share them with people, and what we're doing that we think is changing the way that we treat spine problems. This is actually a 54-year-old fellow from the Bahamas. He's a businessman, and some few years ago, I treated him with a posterior cervical foraminotomy because he had unilateral arm pain. Okay, there you go, motion preservation surgery. And he was better. Then he came back and he had some neck pain, but his neck pain's been getting worse and worse and worse. And this set of pictures here shows you he's a little bit kyphotic in that first MRI scan, but he'd had a foraminotomy there, and the CT scan shows that he's got bone-on-bone discs at 2 levels and did 2-level artificial disc replacement. And these are all cases. In fact, most all of these cases I'm going to show you are all pretty recent. So these don't have a lot of longevity. I didn't do this one 10 years ago. I did it 10 months ago, I think. So these are, as I say, it's a fun talk to give about pushing the envelope and longevity. What about cervical myelopathy? Here's a PowerPoint slide that I just pulled it out of my computer that I gave at the North American Spine Society, a talk on cervical myelopathy in 2005. And Lally Sikon from Australia, actually he's in Reno, Nevada now, if I know where if he hasn't moved on. And I was a little bit critical of, I reviewed this paper, and I was a little bit critical as to whether that's the right thing. And I didn't really have a good idea why. And I still don't. It was like, it just doesn't seem right. Should you be doing an artificial disc in a patient who's got myelopathy and spinal cord compression? And it's like, I was taught this way, but I've always been one, and the guys in the room here that know me, is that I always ask questions, is that why is somebody saying that, and show me the proof and show me the data and show me your experience and just show me whatever you have that's going to prove it. And so it was interesting, is that this is from that paper that he wrote in 2004 and I reviewed in 2005, and I've changed my tune with a lot of these things, which is interesting. I look back at this talk from 2005 and I have this big red circle with a cross in it, that says don't do this. Well, I look at those now and I say, I would do this totally different. I was wrong then. That's what's fun about this. So here's a case that comes across from an ocean, and or a paper that was a hybrid technique for treating multi-level cervical myelopathy, and cervical artificial disc is put at the top of a long fusion. Actually, I reviewed some of these, and I think I probably may have actually put artificial discs at all these levels and not do a fusion. So anyway, I don't know all the answers to this stuff. That's what's fun about it. And across the oceans, they don't have as many difficulties with insurance companies authorizing these things. Trying to get something like this authorized, pretty challenging to get done in the United States. So speaking of which, here's just going on with some of these cases. Here's a young guy that I operated on him a little over a year ago. He's a cardiologist from over in Santa Monica. He was unable to perform catheterizations because of the bad myelopathy that he had. His hands didn't work that he could run a catheter. I mean, he's 42 years old. He's not about to change his career. So I looked at him and said, well, you got two bad levels, another one that's actually not too good either if I did a fusion or did a laminoplasty. He doesn't have a lot of neck pain, but it's mostly myelopathy. 3-level artificial disc, he's back to work. So I can't argue with those things. What about congenital abnormalities? Here's a lady that, and this is a fairly recent case also, 42 years old. She's from Arizona. She found us and she wanted to come see us, and she said, I think you can fix my problem. Is that she has a Klippel-Feil deformity. It's a congenital fusion. It's a lifelong altered mechanics of her spine, right? The adjacent segment degeneration, which interestingly is only above at C7, T1 down below. She does not have any degenerative changes. Treatment's gonna be mandatory at some point. She doesn't have any myelopathy. She's got a wide open spinal canal. She has a lot of neck pain. I sound pretty omnipotent saying things like nature is flawed here. You know, we cannot correct the initial flaw, but why are we going to perpetuate the flaw that nature has done here, right? Going to go do a fusion? That's what I've done them in the past. That's what I used to do. I used to fix every Klippel-Feil case. Okay, you need a fusion, whatever segments are bad. This lady, interestingly, has 2 levels, okay? Why perpetuate this flaw? Okay, we can change the course of the subsequent altered mechanics, and that's why, you know, I look at this, I study these a lot, flexion extension views. I want to study the facet joints. We used to study the facet joints a lot more. Well, we still do. We look at them. We used to do injections. We used to be much more vigilant about studying the facets in every way that we could. We use SPECT CT scanning now, not just plain CT, but the bottom 2 middle pictures show that the facet joints are actually in pretty good shape. And so we also know, I didn't put a slide in, talks about the mechanics of the spine. 80% of the loading is through the vertebra and the discs anteriorly, and only 20% through the facet joints. So this lady went on and she had a 2-level artificial disc replacement. And here's what it looks like. She's pretty happy. Well, time will tell. Time will tell. But it seems to make sense. I like to think that I think logically, at least I hope I do, but these seem to make sense, and we work on these very hard to make them perfect. I mean, if this lady had a big deformity problem or she had some coronal deformity, it may not stop us, but it's going to give us pause. We have done some of those as well. Let's move on to the lumbar spine. Artificial disc. Here's a patient that shortly after the clinical trial closed, this is a guy that came to us and he had 2 degenerative discs, and actually I didn't operate on him. My colleague Todd Landman did and put 2 artificial discs into him, but I had seen the patient before and I thought this was a reasonable idea back then. And he turned up here just in the past year. Okay, so back in '07 he had this operation done. And everybody heard, you know, Charité discs were not very good, but for some reason they worked in this guy, and he does not really have a back pain problem. He now comes in, he's got a neurogenic claudication problem. He stands up, his back and his butt hurt, and he sits and it's okay. So he's got lumbar stenosis, okay? There is a CT scan that shows that L4-5 has got some lateral recess narrowing. Well, I'm having a hard time getting the insurance company to authorize this. I've since done a cervical foraminotomy on him, but I still have not fixed this problem in this guy. But here he is, all these years later, has 2 artificial discs that are working. And if you look at the disc above at L3-4, that's a huge piece of positive information. Okay, this patient doesn't have any degenerative appearing changes just by height alone. I couldn't find the MRI scan, but it looks pretty normal on MRI scan. So preservation of the motion, the mechanics on flexion extension x-rays, I showed those to you before, they look good. I mean, is this just a unique case that happened to survive? Well, maybe it is. Well, here's a case that it's not a motion preservation case, or maybe it needs to be one, or it's in progress. This is a lady who's a physician. She was 54 at the time, and she came to me with a L3-4 degenerative spondylosis, not a very big slip. In fact, it wasn't very mobile, and a lot of pain, a lot of back pain. She had some thigh pain. So we did an operation on her, and I looked at it and said, you know, I think there's one problem level. She's not just a physician herself. Her husband, he passed away, but he's a department chair at a major institution in Los Angeles. So we did an L3-4, we did a lateral, and we did a posterior, we did perc screws, and she's been doing well. but she's now having more back pain. And so where do you think the problem is? Well, you look at the discs above, you look at the discs below. She's had some epidural steroids. She hasn't had any treatment yet. But if you look at her CT scan, what it looks like now, it looks horrible. It looks absolutely horrible. So what are we going to do about that? There's some coronal plane deformity at L4-5. There's also some at 2-3. What am I going to do here, Dr. Kim? You don't have to answer because I don't know the answer either. I'm sure you got an opinion, though.
It's not fusing more.
Well, we may see her back. But anyway, interesting. That one keeps me thinking. Every time I see somebody that has a lumbar problem, I think about this lady. I think about her. I think about, well, actually there's some cervical cases that I couldn't pull up the PowerPoint that were back from the 1970s that one of my professors when I was a resident wanted me to show, and it showed the progression of people like this, having progressive problems. Every 5 to 10 years, they got another operation. So here's a guy, and these are just a few more cases. I got 6 minutes, it looks like. So here's a guy that came to me. He had a herniated disc. I operated on it. He had a recurrence. He went back to Texas and had it operated on there. And then he started having horrific pain. This guy could not work. World famous horse trainer. Everybody in the horse world knows this guy's name. His career was done. He couldn't stand up because he basically has anatomy that when the L4-5 disc collapsed, both of his foramen closed, and the L5-S1, he's got a transitional segment. He's got all kinds of messy stuff in there. So he's got a bad problem. So he couldn't stand and walk very long, nor could he ride a horse. So his career's over at age 48 unless we can fix something. And so we did a hybrid on this guy. We fused the bottom segment and the L4-5 because the only good disc in him, how do I go backwards here? If you look at the upper lumbar spine, he's got one good disc in his back. It's L3-4. Okay, so it makes sense. We've done a lot of hybrids, fusion at 5-1 and 4-5 degenerative, and put an artificial disc in, and presumably is going to help preserve that L3-4 disc because his upper lumbar discs don't look so good either. He's back to work. He's happy. Saved his career, saved mine too. A lot of friends. So anyway, interesting case. Here's another guy in Los Angeles, 61-year-old attorney. I did some foraminotomies on him. He was so happy with that over the years. He's got low back pain, and he's got one degenerative disc in his back at L3-4. And he didn't want a fusion because he liked the foraminotomies I did in his neck, more motion preservation surgery. So we put an artificial disc at L3-4, pretty degenerative level. I mean, in the past, we look at that and say, it's degenerative, why don't you fuse it? Well, how much is too much? How much degenerative changes? And that's why I don't understand when people say they're going to do a hybrid in the cervical spine. Why fuse any segment? Okay, if it's bone on bone, why not? I don't understand. I don't know the answer to these questions either, but I've changed the way I'm thinking about this. I've always been a surgeon that tries to avoid doing fusions unless you do. In fact, a lot of people come see me and they say, Dr. Johnson, we hear you're the guy that doesn't fuse a spine. And I say, oh, no, that's not true. I fuse a lot of spines because they usually come to me with something either failed or have to do an adjacent segment or something. A big part of practice. But anyway, it's an interesting case, and he's still got a few aches and pains, but he's generally better. Here's an interesting one. Look at the MRI scans. Here's a cowboy. He's a former world champion roper a lot of years ago, 40 years ago, but he's still a big name in the cowboy industry. So the upper right coronal MRI scan tells his story. He couldn't stand up and walk. And it also hurt him when he sat on his horse because it's somewhat of an upright standing position. And so this guy's in the horse business. He can't function. And the first thing I thought is, well, he needs a D-lift. Then I started looking at the L4-5. It's got some modic end plate changes. It doesn't look that great. But his foramen is closed. And I thought, what am I going to do here? And I told him, I said, he probably needs a fusion, 2 levels. Be a nice case, right, Terry? A couple of D-lifts and a couple of laterals, perk screws, stand him up, he'd be fine. Yeah, single position, we could do that, that'd be great. And he told me no. He said, that other cowboy that you fixed, I want an artificial disc like him. I said, this one's kind of pushing it a little bit. I said, we don't do much of these things. But anyway, here's his pictures. He's doing okay. He's about a year out. We'll see. Time's going to tell. Because what happens, there's remodeling in the vertebra. The vertebra at L3 and 4, they will lose height on that concavity side. So you can never fully correct these things. If you look at it, there's just some mechanics in there that I don't think we can overcome with the technology we have yet. So there's room for improvement there. So anyway, what are conclusions? Moving away from spine fusion is a natural progression, okay? And I didn't show the slides in orthopedics. Nobody ever fuses a hip anymore. They put an artificial joint in. And in a knee, nobody ever gets fused anymore. So there's lots of non-artificial disc, non-fusion surgery that's still very effective and can be used. So motion preservation still exists without fancy implants. Artificial disc surgery is another natural progression of spine technology, and it's getting better. It is. I think somehow in the past decade, it's been very slow, but I think it's changing. The implants are getting better. I think the surgeons are getting better. I think the surgeons are also getting a little more bold, and the insurance companies are still resisting about paying for them. So understand the mechanics is really, really important. Things like facet degeneration are probably not as important as we previously thought, and the severity of disc degeneration may not be as important as we previously considered as well. So those are two factors that when we put all this together and we digest the information, we're supposed to be real smart and we're supposed to have all the answers. A lot of it is kind of just making an assessment. I think this and I think that, because we don't know the answers, and they're going to be a little difficult to systematically study these, but I think that the more experience we get, the better. So at the end of that, just ride 'em, cowboy. It's going to be an interesting ride. Thank you very much. And I want to end with a little quote from an old cowboy, Cotton Rosser. It's for young surgeons. Be strong, but not rude. Be kind, but not weak. Be bold, but don't be a bully. Be humble, but not timid. Be proud, but not arrogant. The cowboy way. Cotton Rosser. Thank you very much. Time's up. Any questions, comments?
Dr. Johnson, that's a fantastic talk. And, I'm seeing it as a fellow with you in 2008 to now in 2019, the different things that are evolving with you. We used to be the ones that were not doing the arthroplasties, and now I think you're at the forefront. I want to know kind of where the rest of the country is too, because I know there's a bunch of surgeons from the East Coast, Hopkins. Where is everyone's head? Because my head is spinning right now just watching, just listening to your talk.
I don't know the answer to that as well as I'd like to be able to answer it. I think there are a few places where it's slowly evolving. I think there are some places. I talk to people all the time, and I don't think anybody's pushing the envelope the way that some of the guys in our shop are. And I'm not the one that pushes the envelope the most, as you know. There's a few people who push it even more than I do. I think I have a little more caution. But it's gonna happen. I don't know. It's kind of like faddish things. They do happen, out on Southern California. That's a lot of trends. I don't know whether that's just a catchy thing or not, but it's that way. I don't know. Maybe we should ask our colleagues, from Hopkins and other places across the country. What are people doing, right?
Yeah. I mean, that's a great talk. Very interesting cases. To be honest with you, I will do cervical discs. I thought the lumbar discs had, I didn't know anyone was doing them. I know maybe Texas back. I I did a couple early on, kind of, when the ProDisc C finished its ID trial. And I had some good results with a few cases. I don't think we can get them approved through insurance companies anymore, at least where I am. So, I can't say much about it. I didn't really think it was still alive, but obviously there's some cases where it's effective.
Well, I believe it is. We have a lot of experience with that. I think TBI, that's a big factory of artificial discs. I can tell you, just in California, is that I've worked up at UC Davis. Most of the past decade, I put the first lumbar artificial discs in up there not that long ago. One of my former fellows is chief of neurosurgery spine service up there, Ki Kim. He's been a clinical trial investigator for cervical artificial discs, but even in the state of California and right across town in Los Angeles at two university institutions, one place does some and the other does almost none. So I know what happens in our city and in the, around California. I think down in San Diego, there's more being done. I don't think that UC San Francisco is doing that many. I don't know the answers to that. I don't know. I need to go to more of the arthroplasty meetings, I think, to answer some of those questions. But it's interesting. There are places that you're right. I think it needs to keep pushing forward.
I was just going to comment that in our shop, we have 18 partners that are all feeding one guy. We have one lumbar arthroplasty guy. Everybody does cervicals, but the lumbar. And for insurance coverage reasons and then in indications reasons, he's really doing about half a dozen a year from everybody feeding him. But I'm intrigued by the comment that you made, and I always get something when you talk, so I really appreciate the opportunity to be here with you. And that was in 2005, your PowerPoint, you would never have dreamt of doing total disc replacement in the neck for myelopathy, and yet there's a lot of reasons why we would prefer to do that today. And I wonder if that's going to be the same thing with this lumbar stuff, where the initial excitement's over, and now we're kind of in this situation where these really aren't readily available for large swaths of the United States. But you have centers like yours and TBI, of course, that are doing just a ton of these. Maybe we'll get some new indications. Maybe we'll be here in 5 years, and that now all of a sudden, well, of course we do lumbar total disc replacements. I can't believe there was ever controversy about it. So it'll be interesting to see where it goes, and I appreciate the work that you're doing, and I also appreciate the way that you framed it as far as it's going to be an interesting ride. It is always an interesting ride. So thank you, sir.
Yeah. Okay, well, we're going to move on with our next speaker. Danielle, you're taking over, or it's, thank you. Thank you very much.